Professor Ronald Merrell, whom is well known to all of us as Ron. His illustrious career in American surgery and also in the field of telemedicine. Dr. Merrell is Emeritus Professor of Surgery at Virginia Commonwealth University, Richmond, where he was Stuart McGuire Professor and Chairman of the Departments of Surgery from 1999 to 2003. Before that, he was Chief of Endocrine Surgery at the MD Anderson Cancer Center. Dr. Merrell was also a Clinical Director of Virginia Commonwealth University Health System Telemedicine Program. Previously, he was the Lampman Professor and Chairman of Surgery at Yale University School of Medicine. He was the Vice Dean at the University of Texas Health Science Center, Houston, and the Professor of Surgery at the MD Anderson Cancer Center. He obtained BS and MD degree from the University of Alabama, which is his home state, and trained in surgery and biological chemistry at Washington University in St. Louis. Dr. Merrell has had a long relationship with NASA as advisor in aerospace medicine and researcher in telemedicine. He was awarded the Public Service Medal by the NASA in three occasions. He is also a frequent advisor to the Department of Defense regarding telemedicine. Dr. Merrell has established successful programs in industry and government in the field of informatics research. His innovative work in telemedicine includes early use of internet telemedicine, sensor applications, transmission solutions, and program design. His efforts in international telemedicine have led to significant programs in 10 countries and extensive work in remote and hostile environments, including Mount Everest, Amazon, in Africa, and recently his work is well recognized in Saint Verde in Africa, Western Africa. He has long been associated with telemedicine and surgical education program in Pakistan with his colleague Dr. Asif Jafar. As a surgical educator, he has been recognized by the universities he has served and their students with many awards, including the Kaiser Award at Stanford, the John McGovern Award at University of Texas, Houston, and the Edward Storer Award at Yale. He has over 350 publications and serves on the editorial boards of several major surgical journals. Dr. Merrell was named the best doctors in America list for the last decade of his practice. He is Editor-in-Chief, the Journal of Telemedicine and E-Health, the most prestigious journal in the field of telemedicine, the official journal of American Telemedicine Association and the International Society for Telemedicine and E-Health. Ladies and gentlemen, now I present Professor Ronald Merrell to give us the Silver Jubilee Oration. And his topic of the oration is endocrine, specialty of endocrine surgery, what is special? Professor Merrell, please.
Professor Mishra, it's a great pleasure to be here for what I believe is an extraordinarily special event. This is the 25th anniversary for a full department of endocrine surgery in a vibrant and creative institute that has been setting standards and creating generations of new, highly trained and competent endocrine surgeons. This is not a common observation around the world. This department would be extremely well known, as it is, in the United States. Everybody doesn't have one of these. And I know how hard it is because about the same time Dr. Mishra started his department, I opened the endocrine tumor section at MD Anderson, and people were asking the question, is endocrine surgery really a specialty? And if so, what's so special about it? Well, let's talk about it. Initially, it perhaps wasn't a specialty. One could say, well, endocrine structures are, if you want to find someone to operate the neck, go find the neck surgeon, and that's going to take this thyroid out or this parathyroid gland out. If you want someone to take care of a problem of the adrenal gland, go find a kidney surgeon because the adrenal gland is pretty close to the kidney. If it's in a gonad, go talk to the specialist who handle that. The only place where I would never argue is that the pituitary is the province of the neurosurgeons. However, for these others, I think we've learned some things that are important in the care of patients. Well, let us just say that these endocrine problems represent sort of a little lump. Maybe it's just an oncologic problem. Find someone who takes care of tumors and understands the issues of margins and cell type, and so forth, and that's all that's needed. Let's go back a bit in endocrine surgery and tell a few stories. There was some of it came from ignorance. Ignorance is not a bad starting point for some of the best discoveries in the world. Owen was a chap in London who was trying to get his practice started, and he didn't have much money, and he agreed to do a necropsy on anything that died in the London Zoo. And in 1840, he got the call that the great white rhinoceros had died. And Dr. Owen considered how awful autolysis and postmortem changes could be in an animal of this size, so he hurried right over to the London Zoo to do the necropsy. And in doing a necropsy on a large animal, he found something Vesalius had never found, and that were these 4 little glands behind the thyroid gland. He named them the parathyroid glands, and thus begins a long history. He didn't know what they did. The first time a parathyroid tumor was removed with a good outcome was not until 1925. A surgeon named Mendel in Vienna saw Albert, who was a trolley conductor. And Albert was having terrible bone problems, and Mendel was a very well-trained person. And he looked at him and says, I know what's wrong with your bones. It's called von Recklinghausen's disease of bone. And I don't know what to do for it, but have you noticed you've got this little lump in your neck? You can take that out. And he did. And it was a parathyroid tumor, and Albert had a resolution of his pain within about 48 hours. Remarkable. Ignorance led to great discoveries. Well, sometimes ignorance leads to bad results. And certainly in endocrine surgery, the thyroid gland was a nightmare. In 1872, the morbidity from thyroidectomy around Europe was in the 70s. 75% chance you would die if someone operated upon you for a thyroid enlargement. It was so bad that the French Academy of Medicine forbade the operation in France. Don't operate on the thyroid, you're killing people. Billroth in Switzerland, he was in Switzerland then, tried, but he still had a ghastly mortality. And a man named Coker came along and said, their people are suffering from this disease of thyroid. They're suffering. I think if you do it carefully, it'll be okay. His own mortality initially was 13%, but with meticulous technique, he dropped the mortality to 0.5%. That was working in Switzerland, where there's a very serious problem, or there was then, of lack of iodine. And Theodore Coker became the first surgeon in the world to win the Nobel Prize for surgery in 1909, because he had figured out through meticulous care how to operate on the thyroid gland. I would like to think that meticulous technique is an earmark that makes endocrine surgery kind of special. Halsted looked back at Billroth's results, which were awful with the thyroid, and said maybe it's because Professor Billroth operates too fast and is not mindful of blood loss. Well, that could certainly be a problem if you're trying to remove a thyroid gland, and it was. So, meticulous technique. The second thing that made endocrine surgery very special came about through the work of a man named Fuller Albright, who was in Boston. Fuller Albright lived most of the 20th century, and he looked after details. He figured out how to measure things like calcium, how to follow bone alkaline phosphatase. He was sort of a miracle in laboratories, and he had hundreds of fellows. And his great charge to them was always go measure something. They would ask him how something works and what do you call this and why do patients. He was, just go measure something. And then come back to me and we'll see if we can't figure it out. The combination of go measure something in biochemistry, and the meticulous technique introduced by Coker made endocrine surgery what we think of it today or through the 20th century. There's a biochemical diagnosis. There's very careful imaging. There's a profound collaboration between endocrinologist, anesthesiologist, surgeon, and you come up with a collaborative approach in the interest of patients. Otherwise, endocrine surgery is not very successful. It was just a casual take out a lump, or I know a lot of things in the neck, so maybe I can take something out and make you better. I want to give a few examples of these collaborations that were most inspiring and in my own career. Endocrinologists and endocrine surgeons tend to look carefully to see if there's something askew. I recall a patient at Stanford many years ago who had come in for a heart transplant. She was a young woman in her early 20s, and there was a student who had been to the surgical endocrine lectures on pheochromocytoma who was doing her history and physical. While the student was evaluating her, she had an episode of sweating and turned pale. And the student says, "Oh, I'm sorry, I know they've kept you very busy," and you rush down, and she says, "It's okay. I had these sweating spells and turned pale way before my heart went bad." And the student remembered the lecture from endocrine surgery on pheochromocytoma. A happy outcome followed. I removed the tumor, and she kept her heart, because the heart, the myocardiopathy that's associated with high catecholamines, is completely reversible. Where would we be in the casual approach to endocrine if we didn't realize what the lateral compression of the trachea did to the integrity of the cartilage and the evolution of tracheomalacia? So you remove the lump, but now in every inspiration, the airway collapses. Where would we be in endocrine surgery if we didn't have a thorough understanding of secondary hyperparathyroidism and the implications with regard to chronic renal failure? We wouldn't be far, I guess is my point. I think endocrine surgery is special because of the intense professional interaction with our colleagues in endocrine, laboratory science, perhaps pathology, and certainly anesthesia. And I would say with patients. Endocrine patients are a bit special because if your hormones are out of order, you may not be quite yourself. And I would submit that it takes a certain sensitivity on the part of all those managing endocrine patients to be sure that their best interests are kept in the forefront and that we listen to them very carefully about the subtleties of their symptoms. Endocrine surgery is more than the anatomy, but it's exquisitely anatomical. It's more than a lump, but it's exquisitely sensitive to mass issues, whether it's airway or an oncologic margin. It's more than an exercise in biochemistry, but it's deeply versed in the biochemistry of the human organism. Endocrine surgery requires an in-depth knowledge, a profound scholarship, I believe. You can't just be a dummy. It takes a tremendous amount of collaboration, as I've mentioned, and consummate diplomacy. Endocrine surgeons don't do well if they sort of bluster in and say, "The surgeons are here." That doesn't go well. And yet they get everyone together in the interest of caring for patients. This is the kind of surgeon and surgery that Professor Mishra has espoused and made an everyday event in this institution. I hope you're proud of him, because I'm proud to know him. And I believe he exemplifies why there is something quite special about endocrine surgery. Thank you.